Hey guys, how are you? So it's good to see you again. It's been a while since I didn't posted anything in the channel, but I would like to share with you today a nice review about a subject that is not often spoken, which is Amaurosis Fugax. The reason that I wanted to check this review today is because a friend of mine called me. She was in the car driving, and she was reading of the signs in the street, and then she told me that she saw a word, and the word was lacking the last letters. So and she was worried about it, and then she tested their eyes, and there was an eye that couldn't see anything. It couldn't see anything. And then these are AirPods, not earrings. And then after a few minutes, she recovered her vision again. So she called me. I gave her some advices, and I told her that later she should check her doctor. I didn't want to worry her, but as you will see, this can be worrisome. So we have to check this and know this subject so we can advise our colleagues or our general medical colleagues, I mean, or our patients about this entity, Amaurosis Fugax. Okay, so before you ask me why do I have this cap, my hair is okay. Nothing happened to it. I'm in Spain. It's very cold. That's why I have this. It's very, very cold. So today is Monday, December the 30th. So it's very cold. Okay, tomorrow it's New Year's Eve. Okay, so we'll jump right in. Amaurosis Fugax, that is called also transient vision loss. It can be monocular or it can be binocular. The most frequent one is the monocular one. But and what is the cause? The cause of the monocular one is ipsilateral carotid artery disease with secondary emboli throat to the vessels of the eye. Okay, that is the first one. The second one is vasculitis, as in giant-celled arteritis that can cause also a transient monocular vision loss. Okay, so these are the main causes of monocular one. And transient binocular vision loss is less common, and the cause is cortical lesions. Can be as simple as binocular, as migraine, or seizures, or even ischemia. Okay, so I continue. Okay, but there's a very important thing here, because especially a monocular transient vision loss can anticipate future stroke. Okay, so this is why this is very important, and this is why it is important after an event like this to study it a little further, systemically speaking. Okay. So another thing, when the cause is ischemia, it is considered as a form of TIA. What's TIA? Transient ischemic attack. I repeat, transient ischemic attack, TIA. I'm going to repeat TIA a lot in the next minutes. So remember, TIA, transient ischemic attack. Last seconds or can last minutes. And after that, we have a fully visual recovery. So this Amaurosis Fugax is just as we had a central TIA. It's the same, okay? And just that's the one thing. The other thing is that transient monocular vision loss is also has to be differentiated from structural ocular cause of transient monocular vision loss, which can be caused by retinal vein occlusion, for example, which can be transient, drusen of the optic disc, or even optic disc edema. Okay, optic disc edema or papilledema. So we have to differentiate this. So it's not like our patients come to us, the ophthalmologist, and we said, oh, it's okay, go to the cardiologist or go to your clinical specialist. No. We have to check the eyes, be sure that there's no structural damage to the nerve or the retina, and then send them back, okay? With the inform and everything. So I'm going to share now with you let me see, share. I'm going to share this nice, nice review. Okay, I'm sure you're seeing it right now. Let me check if everything is okay. Yes, everything is okay. I'm going to share with you. This is a review article. These are the authors, and it's the current guidelines of management of Amaurosis Fugax and transient ischemic attacks. Okay, the year is 2022, and this is the journal, so you can check it if you want. Okay, so I'm going to jump straight in because I already gave you the preview. So I'm going to review this with you. Risk of ischemic stroke after transient ischemic attack and Amaurosis Fugax. Patients presenting TIA, just as in Amaurosis Fugax, are at a high risk of developing ischemic stroke, both in the short and the long term, estimated to be as high as 10% to 15% at 3 months. This is very important. As an ophthalmologist, maybe the first doctor these patients see. So we have to be aware of that. So we can refer the patient immediately. Okay? In a large multi-center TIA register study, the 1-year stroke risk was 5.1%, and 5-year stroke risk was almost 9%. This is a high percentage of patients. Okay? Okay. The combined risk of ischemic stroke, acute coronary syndrome, or death attributable to cardiovascular disease was 6% at 1 year and almost 13% at 5 years. Okay? More concerning is the fact that a significant proportion of TIA subjects will have an ischemic stroke within the first 2 to 7 days of the index event. This means the first event. Okay? Okay. Prior literature has demonstrated that risk factors for current cerebral ischemic events after TIA include age more than 60 years, diabetes, symptoms duration longer than 10 minutes, and limb weakness. I mean, the posterior, the inferior, the legs weakness, or if the patient has speech impairment as a presenting feature. Okay? Okay, so we have to remember this. I'm going to repeat that because this is very important. Okay? After a TIA, after an Amaurosis Fugax, which is a TIA, we have to be aware that if the patient is more than 60 years old, has diabetes, the symptoms lasted longer than 10 minutes, presented with leg weakness or had trouble speaking, he is in a high risk of developing this ischemic stroke in the first week. So we have to take care of this. Okay. Now I'm going to jump straight to the clinical evaluation of a transient ischemic attack or an Amaurosis Fugax. Okay. I'm going to jump to the important part, which is this. Okay. So it is important to differentiate from Amaurosis Fugax from other causes of transient monocular vision loss. So it is important to assess the patient's own description of visual symptoms, duration of the visual loss, abrupt versus gradual onset, monocular versus binocular, visual loss, associated symptoms, and recurrence patterns if applies. Okay, so the abruptness of symptoms onset helps to differentiate symptoms due to vascular, as in a TIA, from a non-vascular etiology that mimics a TIA, a transient ischemic attack. Okay, because all TIAs have an abrupt onset. I repeat, all TIAs are abrupt. Okay, so as physicians should encourage the patient to provide a specific description of their symptoms in their own words. We have to let them speak to let us know how did it present it, to differentiate if it was abrupt or if it was gradual. Okay. Common Amaurosis Fugax descriptions may include visual blurring, fogging, dimming, shadowing, or complete darkness. Okay, this is very important because we always think that Amaurosis Fugax is complete darkness, and it's not like that. Common Amaurosis Fugax descriptions may include just visual blurring or fogging or dimming or a shadowing. I mean, not complete darkness, just a shadow, a black shadow, or complete darkness, okay, in one eye. The classic Amaurosis Fugax description, although reported by only a small proportion of patients, is that of transient monocular visual loss descending upon the field of vision of one eye, referred to as the curtain or the shakedown phenomenon. It is important to inquire if the patient attempted to close either eye during the episode to ascertain whether the visual disturbance is monocular or binocular. Although most patients do not perform this simple maneuver, they should be instructed to do so in case of future events. Okay? It is similarly important to ascertain whether binocular diplopia or hemianopsia are present, as this would localize outside the retina and thus be an Amaurosis Fugax mimic. Homonymous hemianopia is a typical post-chiasmatical pattern of visual loss due to damage of the optic tracts, optic radiations, or occipital cortex. However, it can be misperceived by patients as monocular vision loss. Symptoms associated with cerebral TIAs can be due to ischemia involving the anterior circulation, such as hemiparesis, aphasia, neglected, or to posterior circulation, such as dizziness, incoordination, dysarthria, binocular visual loss, hemianopsia, and diplopia. Clinical history should clarify whether the symptoms are completely resolved at the time of assessment. Ongoing visual loss may signify the patient is having persistent retinal artery occlusion, okay, warranting emergent stroke evaluation and treatment. Symptoms duration lasting seconds may point towards optic drusen or optic disc edema, including papilledema. Duration between 5 and 16 minutes, followed by headache, may suggest retinal migraine. In younger patients with history of Raynaud, the occurrence of patchy faded vision lasting approximately 1 minute, followed by poor visual acuity without any positive visual phenomena, can be due to retinal artery vasospasm. Any triggers of transient visual disturbance should be noted. Transient monocular visual loss triggered by bright lights suggests retinal claudication from ipsilateral atherosclerotic CIS. Other triggers should, as changed in head or eye position, were reported in certain forms of amaurosis fugax. Also, this ought to be differentiated from transient visual obscurations associated with raised intracranial pressure. Patients should be asked about associated features such as headache, and this can be associated with giant cell arteritis or migraine. So, if you have amaurosis fugax and it's related to headache, it's not only migraine. It can be giant cell arteritis, which is a vasculitis, and you should work up for that, okay? Okay. Positive visual phenomena involving sparkling, flickering lights, marching across the visual field, are consistent with diagnosis of scintillating scotoma as seen in visual aura, okay, as in migraine. Associated eye pain can be seen in acute angle closure glaucoma or optic neuritis. Transient contralateral hemiparesis and sensory disturbance, contralateral homonymous hemianopia, aphasia, or dysarthria can be seen in amaurosis fugax with concurrent hemispheric TIA, okay, which is in the brain. Okay, so we have to be aware of that. Recurrence of the visual symptoms is also important. Patients with transient monocular vision loss from migraine or ischemia may have multiple episodes separated by various epochs ranging from minutes to years. However, multiple stereotypic episodes of transient monocular vision loss recurring over years in the absence of stroke or permanent vision loss suggest migraine pathophysiology. Binocular transient vision loss may also seen during an occipital seizure, during ictal or postictal state. Visual epileptic aura may include elementary hallucinations, flickering lights, star flashes of light, and vision loss, which has been described as blurred vision, whiteout, or scotoma. Post-ictal blindness is typically lasts minutes to hours, but also may last days to weeks. Okay? Okay. And this last part I already read is more specific, not that important. Okay? So I'm going to jump right now, for your knowledge, to physical examination. And then if you want to Okay, right here. If you want to go more in detail, please read the paper. This is for you to listen during your driving to work or while you are brushing your teeth or taking a shower, so you can learn while you do other things. Okay. Okay. So in both cases, this is what we have to do. Okay. Initial set of tests: complete blood count, basic metabolic profile, lipid panel, hemoglobin, TSH, PT, PTT, urine drug screening, of course, it can be caused by drugs, and brain MRI with gadolinium if we are suspecting a central issue. Okay? Okay. Okay, an echocardiogram can be granted. An CT angiogram of the head and the neck can be necessary. Carotid Doppler ultrasound, it's something we should do if we have monocular transient vision loss. And of course, MR angiography of the head and neck can be granted. Okay? Additional study, I'm not going to review because this is more for the clinician. Okay, so this is what we have to know as ophthalmologists. But what should we do as ophthalmologists? And I am going to stop here. Wait, I'm going to see. No, no. Okay, I'm going to stop sharing because there was another article where I saw this other graphic. As an ophthalmology, what should we do? First, of course, a complete visual screening, which means non-corrected visual acuity, corrected visual acuity, stenopaque visual acuity. So we know how the patient is, what the patient visual acuity is now in the time of the presentation. Of course, we already review all the interrogatory we should do. Okay. Okay. Now, after that, we should check visual fields to check if it's not hemianopsia confusing with Amaurosis Fugax. Okay, visual fields. Then slit lamp, very important. Or first slit lamp, of course. We have to check how is the angle. We have to check if the patient does not have an acute angle closure. Okay, because that's another important cause and even more frequent for monocular vision loss. Okay. Okay, we go through the media as usual, and then we should do, if the patient does not have an acute angle closure or an angle that is in risk of closing, we should dilate the patient and check. And before dilating the patient, we should check the pupils. Okay, we should go with our light, one pupil to the other one, to check pupil response. Okay, never forget that. Never forget that. You should point this in your notebook. Okay. Then we dilate the patient and we check the ocular fundus, and we have to check the optic disc. In the optic disc, if the optic disc has something like edema, we will know immediately. But if the optic disc seems okay, we have to look for drusen. Sometimes they are not apparent. Okay, and we should look at the retina. What's the aspect of the retina to see if we have a vascular event of the retina. Okay. After that, after we cover structural damage of the eye and everything is okay, we should send the patient immediately for systemic workup. This is very important. And we already review when is an urgent case that should go right now, or if the patient can go in an outpatient basis to check this work. Okay, now we finished. Remember, these subjects I review with you so you can listen to them while we are driving, half an hour driving. What do? I can listen to music, or we can listen to this channel, to the reviews, and learn. And this will keep our patients better. We do it for our patients. So thank you very much, guys. Okay, cerramos chiringuito. Chao.